My guest today exemplifies the idea of continuous pursuit of controlling your practice and how you spend your time. And she's going to tell us more about that on Practice Care. I'm Carl White, principal at Mark Advisory Group, which is a healthcare marketing agency, and I'm also the host of Practice Care. The mission for both is the same, and that's to help private practice owners stay private. Not only is that what they really want to do, but I'm really convinced that care is better. It's when it's just you and your provider at the table figuring out what's best for you. And there's nobody else secretly whispering in the provider's ear what their agenda is, whether it's a hospital, a health system, owners at faraway lands, whoever it is. When it's just you and your doctor, it's the best chance for the best care. And my guest today is Dr. Ingrid Liu. Dr. Liu is the owner and director of Progressive Health Primary Care. She's been practicing family medicine for over 20 years, and until 2014, she practiced as a partner in a traditional primary care clinic and as a physician in a large multi-specialty organization. Her love of medicine was continuous, but over that time, she found herself spending more and more time dealing with regulations and rules of health insurance companies, this is going to be a theme, and less time taking care of patients. So in 2014, Dr. Liu was recruited to open the first office in Chicagoland for a concierge medicine practice. The concierge model allows doctors to spend more time with patients compared to a traditional practice. And while she did have more time for patients, concierge practices still take insurance. And she still found herself spending time fighting insurance companies. So in 2020, she transitioned again to her practice to Progressive Health Primary Care, which is a direct primary care practice, and she's going to tell us more about what that is. Ultimately, though, it means that she can now devote more time to patient care without having to spend any time dealing with insurance companies' myriad rules and administrative burden. Ingrid, thank you for taking some time to come on Practice Care.
Thank you for having me.
Yeah, so full disclosure, we work together. You've been a client since you opened Progressive or transitioned into Progressive Health Primary Care in 2020. But, and I gave sort of a very high level overview of your career progression, but tell our listeners and fill in some of the blanks about the rest of the practice history, and more specifically, a little more granularity on what concierge primary care practices and what direct primary care practices, and how they're similar and how they're different.
Okay, so when I was in a traditional practice, family medicine, internal medicine, primary care, you're at the mercy of the reimbursements from insurance companies. And so the only way to make more money is to see more patients. And there's only so many patients you can see in a day. And I was burning out pretty badly, much like what is being across the nation, instances where physicians just can only do so much in a day.
Right.
I left that model mostly because the opportunity just kind of fell in my lap to join a startup concierge practice. There are other concierge models that are already established and running, but this was a company that was getting its foot wet in the Midwest area. And so I thought it was enticing. It allowed me to have more time with my patients. And so concierge medicine and direct primary care medicine are both based on a membership model where patients of the practice pay a membership fee to be part of the practice, and therefore eliminates the need to see high volume every day. But as you mentioned, in a concierge practice, all in-person encounters and also telehealth with the pandemic, face-to-face encounters can be billed to insurance for that visit and to kind of increase the revenue. Mm-hmm. And the rules of that, however, are that all the membership payment fees have to fall outside of services that are for healthcare, for medical services. And so specifically, Medicare is the strictest of all of that, but all of the insurances you contract for payment for medical services. And so you have to be very careful in following those rules and saying that these membership fees that you're collecting are specifically for kind of other additional perks, really, and for access, for not even for after hours care, because as part of your rule of your contract is that you're available and have on-call coverage for your patients. So you can't even say that as being the reason why you can charge an extra fee. So it gets pretty tricky. And
It
so
sounds like threading a needle over and over again.
it is, and
Yeah.
it becomes, and over the years, the language in these insurance contracts have become more and more difficult to get around in terms of what's allowed and what's not. And so as a physician, physicians are not very good business people. We want to help people. We tend to be altruistic and very giving, and we give, advice and care all the time, all day long, to patients who need it. And we don't worry about the fine print lots of times. And so it does get pretty sketchy when someone calls you out and says, well, you're saying that this is part of the membership, but why are you also billing insurance, that you're double dipping, right? So I didn't like that. And then on top of that, I felt that people were paying a fee and expecting to get their health kind of care and coverage as included. It was too hard to kind of explain. And so it attracted, unfortunately, it was kind of, it left a lot of people who couldn't afford it. And because you're not only paying for your, healthcare insurance and the membership, and on top of that, any balanced billing that suddenly, if the insurance comes back and says you have a high deductible or this is not covered, the patients are obligated to also pay that balance to the physician, or you have to try and collect for it, and it ended up being more out-of-pocket expense for the patients, and I felt bad about that. Okay. So then I discovered that there is this newer model called direct primary care, which is kind of gaining in popularity in mostly rural areas because the options are less there. Right. But also, now in, urban areas as well. And it eliminates insurance altogether. So, the physician still sees the patient just like normal and still has the membership fees, but then that's it. You don't have to try and guess what something is going to be covered or not, and cross your fingers when you bill, and see what kind of additional. And on top of that, the reimbursements were getting less and less and less for all the trouble of submitting and resubmitting and providing the documentation and checking the boxes and crossing the T's, and for $20, it's like, right. And then the patients still have to pay the copays on top of that for every visit. So it just made more sense to me. And I think it makes more sense to patients, except that, yes, you're still having to have health insurance and pay for that in case of other, issues and emergencies, or if you need to see a specialist, but for everything that's done inside of the walls of my practice, there's insurance is not involved in any way.
Yeah. Sometimes because I'll say, I've got this client, she does direct, but what's direct primary care? And I say, well, have you heard of concierge? Yeah, I've heard of, all right, take that, subtract all health insurance, and it's the membership fee pays for all but the very rare, modest, couldn't be predicted, lab test or something, depending on a patient. But for the most part, it's the membership fee. And it's everything else is this. I mean, it's still lengthy visits, still same day. And it's still all the same things that a concierge model promises, but there's just no insurance. And that's the only difference. Oh, I get it. What are like a couple of like really egregious examples of insurance company battles that you faced? Because it seems that is obviously the heart of why you kept deciding to find a model that worked for you, because they just were always there. So what are some just like really horrible examples?
Well, I can name specifically, while I was still in the concierge model, I had a patient who had, to try not to be too graphic, but had a pretty decent size abscess that was infected in his leg. And so I had to drain it and send off the cultures, pack it, and then see him in follow-up for, and numbed it up first, all these different additional charges, billed for those charges to insurance. And the insurance refused to cover it. And so the patient had to pay something like $1,400
Hmm.
for that visit. And I had to continuously provide more documentation in the notes over and over again, even though the same notes were sent over and over, until the insurance company finally said, "Oh, it's because you're a primary care physician and not a surgeon, and we don't pay for this for primary doctors. It's only you have to be a specialist to cover it."
Oh my
So
God.
that's one very, very egregious situation. So I still luckily had the membership, payment from the
Yeah.
patient to support, the bills of my practice. But I got nothing in addition to that, which is basically like a direct primary care practice.
Yeah.
So rather than spending all those hours and faxes and,
Yeah.
phone calls, just to find out that I was, valued much less than a specialist by this insurance company, I just said, okay, I'm not
So
doing
did
that
you ever
anymore.
say to them, should I have sent this guy on his way to I mean,
It doesn't matter.
yeah, I know, but I mean, you're just
um,
like, but come
yeah.
on, yeah.
Yeah, and so another case is, well, this is not really my services, but for an instance, there is a test called the Cologuard, which is a stool test to screen for colon cancer,
Yeah.
and very healthy patient with no family history, very few risk factors, decided wanted to do that instead of for a colonoscopy.
Hmm.
And so the insurance company, commercial insurance company, said, this is not covered, and billed the patient $600 and something dollars. Whereas with her deductible, had she decided to go for a colonoscopy, the cost out of pocket for her would have been $3,000. So she knew
Hmm.
this and paid it anyway, but I provided letters to say, you can pay this $600 for this test rather than risk complications from anesthesia, infection, all these things, and pay the hospital their fees.
Hmm.
Or you can pay it. Of course, it didn't matter. They still didn't cover it. But I could probably try and figure out how to order that and do it in my office for less cost. But it's the lab, so I can't really have
Yeah.
any control over that. But that's another nonsensical insurance decision.
Yeah. Yeah. And I learned more from you about, well, not so much anymore because you're not dealing with it, but between different clients that I have,
Yeah.
yes,
And
the
the problem is,
counterintuitiveness.
the patients, it's impossible for them to know, that I really have no control over any of that.
Yeah.
They think that just because the doctor orders it, that it'll be covered, because I have the ability to decide what is justified and appropriate, right?
Hmm.
But the insurance companies don't care about that.
No, they seem to have this part of what I said in the opening. It's they're sitting at the table and not helping
Right.
anything.
Yeah.
Yeah. So you've made, I'll say, two major transitions in your career, right? I mean, it's always been primary care, but different, very different models. And at any given time, I mean, it's a big deal to make these kinds of changes. So it's a risk. It's what's going to happen? Is it going to work? And a lot of people don't make it. They just say, you know what, I'm just going to ride it out because I'm stuck, or I don't even think it that deeply. Why didn't you just swallow all this and just keep going? I mean, what made you say, I don't know what it's going to look like, but I got to try this? Like what got you over those humps and kept going?
Well, it was either change or quit.
Really? Okay.
There was no option to continue in that capacity for me.
Okay.
Yes, there are physicians that are doing it, and more power to them. And but I've never been able to crank out patients every 10 minutes, which is
Mhm.
what is um, kind of the norm nowadays.
Mhm.
I was increasingly crabby, unhappy. I constantly felt that I had one foot out the door to go to the next patient because I was running behind and not focused on the patient. And maybe that's just my lack of ability to do that. And I, no matter how much I tried to increase my efficiency, whether it was with dictation and like getting in and out of the room and using medical assistants and all that, I just didn't have it in me. And so I think for my personality, it just didn't work. And I felt like I was missing, really important information from patients. I could never get caught up. I was constantly drowning in paperwork, and yeah, my inbox was, like 40 messages by the end of the day. And I have to get up and go back again the next morning and do it again all over again. So, the days were getting longer. I was getting less satisfaction. And I really did not feel like I was providing my patients with the care they needed. So for me, it was either do it right or don't do it at all.
Okay.
So I was seriously looking into, I don't know, some other non-medical profession.
I was going to ask you, did you have like I'd go here if I just quit this one day?
Well, part of the reason I didn't was because I didn't have a backup plan. So it would have been riskier to do that than to just change the model of practice, which fortunately, I could have done urgent care or employee health, or like fortunately in family medicine, you have options. Some doctors change and do chart reviews, that kind of stuff. So you're still using your knowledge. My former primary partner in private practice left clinical medicine and went into the pharmaceutical industry in research and development. So, there are options, but I really was ready to just hang it up.
Yeah. Wow. So would you recommend direct primary care to other family practice physicians?
Absolutely. I mean, I'm not going to lie. You have to have a little bit of, knowledge of how the business runs. You have to be a little bit more in terms of that. And again, physicians are not good business people. I think had I not slowly transitioned and learned the ins and outs with this concierge, because I was employed by that, but also given the freedom to run the practice how I wanted. It was a steep learning curve, but it helped prepare me to be able to do my own direct primary care practice. So I had a little bit of a transition there that allowed me to kind of learn from some mistakes. So, that was a bonus. And I think there are some residents coming right out of training that are going into direct primary care, and it's a little bit lonely. The model is more either a 1 doc or 2 doc practice, or they're small practices. If you don't have people to bounce things off of, or have like a good Rolodex handy, and you're coming straight out of training, I think that's difficult. I have 20 plus years of experience, like you said, with a really good base of specialists that I refer to and people that I can call, and and that I think helps. The patients expect you to have like a lot of kind of stuff in your back pocket to be able to guide them, and not just refer out every little thing, or say, not have that knowledge to go off of.
Right. What's the best part for you about DPC? What do you think the best part is just about it?
Not dealing with insurance. It's so much more simple. My bottom dollar and my take home pay is less, but it's worth it for me. I enjoy medicine again. I have the time to research all the new stuff, and with everything that was going on with COVID, had I been in a traditional practice, there's no way I could have kept up with everything. I have time for my family. I can do house calls again, and not have to think about, how much am I going to get reimbursed for this? So, yeah, I definitely think it's better. And again, without all those rules and regulations, I can just focus on
Right.
giving a patient what they need.
Right. It's interesting. You go to medical school, you learn how to do things, you go residency, you gain experience, and nobody ever tells you you're going to have to compromise with insurance. There's no class
I
on it,
don't,
I imagine,
I don't have to worry about coding.
Yeah.
That is probably the number one bonus of not having to do with insurances. I don't care what the codes are. Yes, I have to have diagnosis codes for, lab orders and x-rays and things like that, but not for reimbursement. I don't
Mhm.
have to worry about any of that.
Wow. Now, for somebody who's thinking about DPC or they're just interested in it, what's something like that you think they need to know, but they just wouldn't know until they got into it? They'd be beneficial for them to know beforehand.
Um, I think it's more, yeah, you should have a good idea of your population of patients and educate them and know if they're willing to cover that membership price. And
Yeah.
it's different. You can set whatever your membership price you want. So if you look at different practices in different geographic locations, there's no like one rule. Probably the best advice I can give is that the physicians that have made this change want everybody to succeed and are more than willing to provide leadership and advice. There are forums out there, there are conferences, there are Facebook groups,
Yeah.
everybody willing to help each other. You don't have to do it on your own. You don't have to research it all. People even share their forms, their consent forms, and it's pretty amazing how much it's not competitive. The physicians want this model to succeed and to spread and people to realize how much it can enhance their practices. And so that's probably the one thing is don't be afraid to get guidance and help from other people that have done it. I mean,
Okay.
that's probably the best advice.
Okay, great. Cool. Well, we could spend a lot of time. There's a lot more questions I could ask, but in the interest of keeping it to our bite-sized advice for the business side of practice, I'll say, Ingrid, thanks for coming on Practice Care and for sharing your experience about DPC and why you made the change and why you kept going. I think it's really beneficial for other people to hear. We
Thank you.
will put your contact info, like at least the website and stuff in the show notes, that if somebody wants to reach out to you to ask more questions, they'll be able to do it. And a couple of other points before we wrap up. If you are like Ingrid Liu and you've got some experience on the business side of your practice, or if you're someone like me that services private practices, we'd like you to come on Practice Care and share your experience so that others can benefit from it. In the show notes for the episode, there'll be a link where you can just fill out a quick form, tell us what you want to talk about, and we'll get you scheduled as soon as possible. And then finally, if you haven't done so already, please subscribe to Practice Care on Apple Podcasts or wherever you listen to your podcasts. Thanks very much. And until next time.